Good evening and welcome to Doctors on Call. I'm Dr. Paula Termuhlen, Regional Campus Dean at the University of Minnesota Medical School Duluth campus, and I'm your host for our program tonight on cancer, surveillance and prevention. Our panelists tonight are Dr. Brett Friday, an oncologist with Essentia Health, Dr. Addie Vittorio, a family medicine physician with St. Luke's Mount Royal Medical Clinic, and Dr. Sandy Stover, a family medicine physician and faculty member at the University of Minnesota Medical School Duluth campus. Our medical student volunteers answering the phones tonight are Jacob Bentley of Austin, Minnesota, Zach Hartnedy of Hutchinson, and Chris Wigger of Brainerd. Please call in your questions about cancer prevention and surveillance, and we will do our best to answer them. The telephone numbers for those questions can be found at the bottom of your screen. And now, on to tonight's program. So Dr. Friday, let's start off by talking a little bit about what happens after cancer treatment. Questions that patients ask me often are, well, is that it? Will anybody ever be looking out for me?
Well, I think that's a huge part of the whole continuum of cancer care. I think most of the time we often focus about the treatment part, and it's that's sort of the active part where patients are whether they're having surgery or chemotherapy, but it's this treatment part we tend to focus a lot on. But the reality is, I think as our treatments have gotten better, we have to think about the rest of a patient's life. So it's not just that time during their therapy. And so we've made really enhanced efforts to try to take care of patients after their treatment is done. And that's both thinking about what is the risk of recurrence and how do we watch for that? Because almost any time we treat a cancer patient, despite our improvements in care, there's always a risk of recurrence. But so one part of that's surveillance for risk of recurrence. But I think the second part of it that's almost more important are how do we take care of some of the issues that arise from the treatment,
right.
And whether that's symptoms related to the surgery or symptoms that are outcomes of chemotherapy, side effects. And these can sometimes be lifelong issues that we have to watch for, as well as a potential for risk for secondary cancers down the road.
Right.
And so within our clinic now, we have a cancer survivorship program that we meet with patients, a specific survivorship meeting typically at the end of treatment phase, and provide patients with a clear plan that outlines what treatments they had, what the risks of side effects were, what they should be looking for long term. And that plan is provided both to the patient as well as to the patient's primary care provider, because we think that's an important part of a long-term follow-up. It's not just your cancer doctor, but it's the primary care provider. I think it's just as important in watching out for these things.
So to put our two primary care providers on the spot tonight, what does that look like in your clinics?
Well, I think it's a good opportunity to be part of the team that takes care of cancer patients, to walk them through assisting with the cancer docs, but then afterwards helping them become more comfortable again with some of the changes that have happened, and some of actually this being a little bit scared about it coming back again, and working with some of the spiritual and emotional changes that can come with cancer too.
I think the other role that I have as a primary care provider is to realize that this patient is not just a patient who has survived cancer, but that we need to continue screening for other cancers and other diseases as we would in any patient. The other role I think I have is that seeing patients who are part of a family and have siblings or have descendants is looking at what are their risk factors for cancer and urging them to get screening and testing and other things to prevent the cancer.
So that's actually a really interesting place for us to start a conversation that will be, I suspect, quite a bit of what people are interested in too, which is, how do I find out if I have cancer? What are the kinds of screening tests? And we recognize that may change depending on whether or not you're just sort of part of the normal group of people, or if you have maybe a higher risk that's been identified. So let's talk to start off with about something that I think everybody hears a lot about in the news today, and that would be mammograms, right? And so, Dr. Stover, talk to us a little bit about how those mammogram rules have changed in the last few years.
And I think actually the changes reflect better science on what outcomes we're seeing in good studies supporting how often you need to have mammograms, what's the risk of a mammogram, how many, at what age would you kind of start thinking about whether you need to continue mammograms. And I think I believe that the best advice is something that you have in a conversation with your primary care physician. But generally, the recommendation is to start regular surveillance or regular screening at age 50. There are some times when we will screen before 50, and that's a conversation again to have in specific one-on-one. Between 50 and 65, you're going every year to every 2 years is very reasonable. After you reach a point in your time where you wouldn't necessarily do something about the information that you find, then that conversation needs to happen too about whether you want to continue screening or not. Yeah.
And Dr. Vittorio, how's that look in your office?
I think very similar. I mean, women at the age of 40 often come in expecting to get their first mammogram, and it's a conversation that it's an opportunity to talk with them about whether they have risk factors and when they want to start. But in general, every 1 to 2 years between 40 and 75 is what.
That upper limit is really kind of a question mark.
Yeah.
And I think that, Dr. Friday, you take care of breast cancer patients too, and it's a little bit different if somebody's actually had cancer.
Right.
So what kind of recommendations do you give your patients?
Well, I think specifically, if there's a specific question regarding, when to stop, I think in all of these questions we're kind of talking about, a lot of it's, what we call it, shared decision making, talking to patients, because, we can talk about an age, whether it's 40 to start or 75 to stop or 80 to stop, but those are just numbers. And, each patient is different, and assessing their personal risk for cancer, within themselves as well as family members, and their other, overall health, I think filters into that. And so, when to stop, I think is a discussion. It's not just a specific age that at this age we're going to stop doing screening mammograms. It's talking to the patient and assessing their health and kind of making a more educated decision about when it's reasonable or appropriate to stop doing mammograms.
And I think we ran into that with pap smears and the most recent changes, because pap smears actually are a pre-cancer screening test, and so it's really hard to sort of adjust to new recommendations and when to stop and why, but it's a good conversation to be having with our patients.
Yeah.
So we have a question from Janice in Virginia who'd like to know, what is the main cause for brain cancer, and specifically in relationship to family history, and especially if someone's had someone in the family who's died from brain cancer?
Well, that's probably an appropriate question for me.
Yes. Go for it.
First of all, to define brain cancer, I presume the question more relates to primary brain cancer, which means a cancer that starts in the brain. It didn't start somewhere else and spread to the brain. So, primary brain cancers is one that, frankly, we're still learning what causes them. There are certain risk factors that we know about. For example, high-dose radiation exposure, but that doesn't affect many people.
Right.
There are some differences between men and women, so there may be some hormonal effects. There certainly appears to be a slight influence of genetics and inherited features, so within families there may be a slight influence, but it's not a direct, if mom or dad had it, that a child's going to get it. It doesn't necessarily mean that. It's a slight increased risk. And so unfortunately, brain cancers are one that we still don't fully understand the specific causes for them. We know some of the risk factors, but in general, they're pretty small risk factors. And so it's a tough area to study, as opposed to some other cancers where we clearly know, very significant risk factors for cancer development.
So we have another question from JD in Cromwell, who'd like to know, what are the main signs and symptoms of rectal cancer? And I suspect that both of you have seen that in your office.
Well, and that's a good question, because there does seem to be a little bit of a rise in the occurrence of perirectal cancers. And I think one of the biggest signs always in any kind of colon cancer is a change in bowel pattern, but pain in the rectum, pain with passing bowel movements, bleeding that doesn't have a known source like a hemorrhoid are all things that I would be very concerned and do more of an exam on.
So we have a question here from Lucille in Saginaw, and who says that there's someone who has a sister who's had ovarian cancer and a paternal aunt, so that's on the father's side, with breast cancer, and wonders if this is someone who should get a BRCA2 test. So there's a lot to unpack in that particular question. So let's first tackle, how do we take a look at these family histories, and when in your practices do you identify someone that you think probably should be screened?
I personally take a family history every time we meet a patient or we do a physical, and if there appears to be multiple cancers that may be related, such as ovarian or colorectal or breast cancers, in first or second degree relatives, first of all, then I will talk with a patient about more of that history or make sure that it is a true history. Oftentimes I will request that they have the family members who have had cancer be tested, because insurance typically regulates that, and we don't do a lot of screening for family histories of cancer. And then I may refer them to a geneticist to have a discussion and to delineate their family history a little bit further, and then give more specific recommendations for that.
And so I was just going to say to Dr. Friday, who again, I know that you refer patients for genetic testing. What does that look like, and maybe some of the guidelines around who's the right person to send for that?
So I think for this question, with ovarian cancer, unlike the question with brain cancer and risk, certain genetic mutations like in the BRCA genes are very powerful risk factors for developing ovarian cancer. And so from a cancer standpoint, our current recommendations are any patient who's diagnosed with ovarian cancer should be tested because there's such a high likelihood of finding a mutation. So any patient with ovarian cancer should be tested. What testing really looks like, and testing always goes through a genetic counselor to really talk to the patient about what the testing may find and mean, and also to talk about if they test positive, what happens next, because of course this is an inherited factor. So if you do find a mutation in a patient with ovarian cancer, really the next thing to do is to talk about who else within the family to offer testing to. And I think you brought up kind of coverage for testing. Most of the time, the best person to test is the patient with cancer.
Right.
And so, for ovarian cancer, it would be that patient with ovarian cancer. It's very difficult, unfortunately, sometimes to get coverage if you want to test another family member who, that didn't have the cancer. So you always kind of tend to start with the person with cancer, and then it would filter out from there to other family members and offering testing if you did find a mutation.
Well, and I've heard recently that some of the companies are actually offering sort of a window of testing for additional family members. This has become very popular just very recently, that if a family member is found to have a mutation, they'll go ahead and test for free other family members within a certain window. So I think the moral of that story really is that people should not be afraid of the testing. They can be empowered to get tested, and should they find a positive result, then there may be some additional things that they can do to help protect themselves or to change their screening, right?
Right. Absolutely. I think it's very important to know that. And the other part, often the questions come up about testing is, concerns about things like insurance coverage in the future, and to know that there are laws built to protect patients with that genetic information. So that shouldn't make people hesitate to get tested, particularly for genes like BRCA that have such a strong association with cancer risk.
And one of the other aspects of this I think they're currently exploring is this is an opportunity for telemedicine counseling to go on, so that so Dr. Stover, who was in practice in Grand Marais for a number of years, we would hope that in the future we'll be able to do telemedicine with genetic counseling for those patients that might come in
from farther distances.
Farther distances.
Yeah. And I'm actually finding that some insurance companies will have their own genetic counselors and provide that service for patients as part of their coverage.
That's great.
Yeah. I think anytime we do testing of family members, or we look at sort of, are you more at risk because your mother or grandmother had ovarian cancer, then you have to look at, well, what's the follow-up for that? What does that mean for me if I test positive? And it can mean a variety of things. It may mean that you would consider a mastectomy or consider a hysterectomy with your ovaries removed if you were at high risk for that. It may simply mean increased surveillance.
And so really part of that is educating oneself and then not being afraid of getting more information. And then, as we always like to point out here on the show, it's important to have those conversations with your physicians and who they want to be part of that team. So here's an interesting question from Sandy in Duluth, who says that there's been an incident where a white count, the white blood cell count, was flagged as low. And should she be concerned about that, and how low is too low, and could it mean cancer? So I think this really opens a nice opportunity for us to talk a little bit about general lab tests that might be done as part of a physical exam. I'm going to put Dr. Friday on the spot to address the low and high white count piece, but then I'd like to hear a little bit about the kinds of things that you might identify in your practices. So Dr. Friday.
So a low white blood cells are really part of our immune system, and the challenge with a low white blood cell count is it could mean many different things, ranging from even an infection can make it go low, but to liver disease, to vitamin deficiencies, to thyroid problems, to cancer. So, of the vast array of things that can cause a low white blood cell count, yes, cancer is one of those, in particular bone marrow cancers. And so I think it just generally fits into an abnormal lab test. It's abnormal, it needs to be commented on. And I think that's a very appropriate question for whoever ordered that test for that patient, as to why do you think it's low, and does this need to be looked into further? But it's also to know that for a low white blood cell count, many things can cause that aren't cancer. And so just because you see that, it doesn't necessarily mean that there's an underlying cancer problem, that it could certainly be other things that aren't cancer related.
And all of our labs have a standard value that may vary from institution to institution. So you can't necessarily take your labs, go on the internet and say, well, this is low compared to what I found on the internet, because it varies even hospital to hospital. So that's again a conversation best to have with your clinician.
I think it's such an important point. I personally have had to counsel patients who, particularly in their post-cancer setting, where they'll have lab tests drawn and they'll be abnormal in some form or fashion, and they're very concerned about that. I can imagine when we have individuals coming in who are just coming in for the routine physical exam, something's not quite right, and so in general, recognizing that they should be having these conversations. So Dr. Stover, can you comment a little bit about how do you follow a patient for that if they have that abnormal lab?
Well, and I was going to comment that there is no single lab that tells you the whole story. So we do labs as one piece of information in a whole arena of information to come up with ideas to help best counsel a patient. Honestly, if there was a single lab value that was out of whack, I would also wonder if the lab test itself had been coming through correctly. Life is full of things that don't always work exactly correctly, and labs are sometimes part of that, and I would repeat it first. And then look at what symptoms, what history, what family history might be contributing to making me want to look more closely or do other more definitive tests than the screening tests we do, as most of our lab panels are.
Yeah, and I would caution people that we don't necessarily screen for leukemias and lymphomas, which are blood cancers, as part of a normal physical. A white count, a blood count is not a normal part of a physical, such as cholesterol and other labs such as blood sugar.
Great. So we have a question here from Zach in Duluth, and we're going to turn the tables now and start talking about colon cancer. So Cologuard is a product that has come out recently, and how effective is this in cancer screening, and is there still a need for colonoscopies?
It's a good question all around, because there are several things out there that can effectively be used for screening for colon cancer. And again, when we're talking about screening, we're talking about people with no other risk factors, just the average normal person at normal aging way. So you can do a colonoscopy, which is sort of the gold standard every 10 years.
What is a colonoscopy?
And a colonoscopy is a fiber optic opportunity to look at the inside of your colon, which does require some anesthesia, and it does require some preparation. So it's a little more costly, and it's a little bit more load on the body, and with potential other risk factors that can come. It's a very simple test overall, done frequently without too much problem, but there's a little bit more associated with it. The simplest test is a simple stool test for blood in the stool. The most common right now is called the FIT, the fecal immunochemistry test, looking for blood, human blood in stool. And in between there is the Cologuard, which looks at blood, but also looking at some of the genetic markers for colon cancer. The recommendations currently that is equivalent every 3 years to a colonoscopy every 10 years. But again, these are screening, and if you had a positive test on a Cologuard or on a FIT, you would then go to a colonoscopy to have a more gold standard look at the lining of the colon.
And I think what we have been learning as we've been using this test for the past year or 2 years is that no test is perfect, and we actually do get a fair amount of false positives on our Cologuard, meaning patients test positive, they're concerned about colon cancer, they go on to have a colonoscopy, and that colonoscopy turns out to be very normal. And that's a part of any test out there. But as with anything, it's going to take some time to play out what is the best non-invasive test, and by all means, the colonoscopy is considered our best test, but also our best treatment for early cancers.
So at what age do you think people should start getting that colon screening?
Well, the new recommendations are 45. We have yet to see sort of the major organizations sort of say that is the recommendation, but that came out earlier this year. 50 has typically been our routine screening.
And if there's a positive family history, the recommendation is 10 years before that family member developed a cancer.
Oh, good. So Pat in Warba has a question about needle biopsies and breast cancer. And is it worth pursuing after someone has an abnormal mammogram? So who wants to field that one?
My thought, personally, and as a physician, is if you find something abnormal, I would want to know what it is. So a biopsy, and a needle biopsy is probably the simplest thing to do if it is appropriate for that finding. But if you find something that is concerning on a mammogram, it's typically calcifications or white spots that light up on a mammogram, and most people would want to know what that is so that we can give further recommendations about whether to be worried or not.
Not all spots, unfortunately, are going to be retrieved with a needle biopsy, and that may be part of what that question was asking. And there are a variety of ways of getting a piece of tissue so that our pathologist can take a look at the actual cells that are involved in that X-ray abnormality of the mammogram. You know, every test we do sees one portion of what's going on, and a mammogram sees an X-ray evaluation, but the tissue pathology is where that information then goes to the oncology folks who can best guide then, you know, what treatment is best.
And I think you have to listen very closely to the radiologists who read the mammograms. And you know, in general, they're very good at when they read these mammograms that is it something they're concerned about or not. And so sometimes their recommendations are, there's a little spot, I'm not really all that worried about it. I think we should maybe look at it a little bit sooner than normal, but it's not something at this point that I feel that should be biopsied. Whereas if a radiologist who reads these, you know, and very good at reading them, says this is something that should be biopsied, I absolutely agree. It
Go
should
right to it.
It should go to a needle biopsy.
And another nice tool is an ultrasound, and I think our radiologists use both of those tools together to see two different sides of what they're noticing on the breast. But definitely, if a radiologist said there was an abnormality that required further workup, I would definitely support that.
So we're getting close to the end, so we'll have just a couple more questions here. And here's one from Billy in Medela, who says, does alcohol consumption play a role in liver cancer?
Yes.
Absolutely.
Absolutely.
It does.
Yes, as does, you know, for all cancers, as does other habits such as cigarette smoking, lack of exercise, obesity, stress.
Okay. So we have so many questions. There's one area, though, that we want to make sure we touch on, and I think that has to do with a vaccine for prevention of cancer, the HPV vaccine. Can we talk just a little bit about that, again, recognizing we only have a few minutes here?
The HPV vaccine is one of the first vaccines available that directly impacts cancer occurrence. And primarily the human papillomavirus, which can be transmitted in a variety of ways, primarily sexual interaction. But that virus leads to cervical cancer. There is an increasing evidence that other kinds of perirectal cancers, throat and mouth cancers can also be involved with that. And the data is really clear that if the vaccine itself, it makes a huge difference in the occurrence of that. It's been available for not quite 10 years, and the data is already showing significant drops in the occurrence of cervical cancer.
Right, and I think some of the data supports, you know, almost more than a 90% reduction in cervical cancer.
Just huge.
Which, you know, really sort of takes it to the category as a cancer doctor, something that years down the road, if everybody's up to date on these vaccines, that's not a cancer I will see. You know, because this vaccine is so effective at preventing cervical cancer.
Absolutely. So, Dr. Vittorio, at what age do you normally recommend your patients to get that vaccine?
Well, our earliest age that we are allowed to give the vaccine is 9, but we typically would give the vaccine between ages 11 and 12 as part of routine vaccines at a well child visit. Recommendations just changed so that we can vaccinate persons up to age 45. And so we are vaccinating adults now, wherein last year we were just vaccinating individuals under the age of 26.
And is it just boys or just girls?
Women
or
and men.
both?
Yeah, and I think it's helpful to know too that it does seem to be a little more effective if it's in earlier ages, but at ages up to 45, there's definite benefit.
Yeah.
And even in women who've already had abnormal PAPs, that the vaccine is still helpful in reducing risk down the road.
So what we're really talking about is one of our best ways of preventing cancer is something that can be incorporated as part of a routine examination over time. And I think the dream of never seeing that cancer again is something we hope that we'll achieve in our practice lifetimes. So we're coming up to the very end here, and I just want to thank both, all of you. Dr. Brett Friday, Dr. Addie Vittorio, and Dr. Sandy Stover. I also want to thank our medical student phone volunteers, Jacob Bentley, Zach Hartney, and Chris Wigger. Please join Dr. Amanda McDonald on January 10th for a program on childhood poverty and health, when her panelists will be Dr. Lisa Benger, Dr. Nicole Greschel, and Dr. Heather Winsett. Thank you for watching. Good night.